Welcome, everybody. Today we're talking about domestic violence routine screening for non-government alcohol and other drug services. I'm Michelle Campbell, the Clinical Director at NADA, and joining me today is Millie Taylor, our Clinical Program Manager. Firstly, we'd like to acknowledge the lands of the people we're on today. I'm on Wiradjuri land, and we recognise the continuing connection to land, sky, and waters and thank them for protecting this land. We pay our respects to elders past, present, and emerging, and extend that respect to all First Nations people. We acknowledge that sovereignty has never been ceded, always was, always will be Aboriginal land. We also recognise the contribution of people with lived and living experience. We proudly recognise that people with lived and living experience of alcohol or other drug use play an important role in shaping policy, education, and services. We acknowledge that through their guidance, diverse experience, and peer support, lives are saved and health outcomes are realised. We acknowledge that this participation takes real courage, gives a voice, and reduces stigma and discrimination in our community. Before we start as well, we'd like to just highlight a couple of resources. The first one is Language Matters, and we acknowledge that language is powerful, especially when we're talking about alcohol and other drugs and people who might use them. Stigmatizing language reinforces negative stereotypes, while person-centered language keeps the focus on the person. The next resource is the AOD Care Charter. So the Care Charter guides all staff to deliver care that is safe, accessible, equitable, and non-judgmental. It aims to improve the experiences and health outcomes of people who have used or are using substances. This resource was co-designed with 10 people who have used or are using substances, 5 clinicians with diverse expertise, and members of New South Wales Health, NUA, and NADA. The QR code on the screen takes you to the website, which has additional resources and information on how to implement the charter. So looking at our learning objectives for today, this video is part of a suite of resources to support non-government services to implement domestic violence routine screening for all women accessing services. Other resources in the toolkit include policy templates for the DVRS tool and also a policy template for identifying and responding to domestic violence, which includes working with people who use violence. We have a NADAbase video to navigate the changes in NADAbase for people using that, and a practice tip sheet with scenarios to support learning sessions. So a bit about the background as to why we're doing this. So the domestic violence screening tool was implemented in 2017 when NADA worked with the network of women's services and domestic and family violence experts to develop a screener to explore the experiences of domestic and family violence with women accessing NADA member services. Questions were built into NADAbase so that screening became a standard part of practice rather than something that was tacked on. This work was sector-led and grounded in practice expertise. It's really important to ensure that staff are trained and confident in using this tool. So training was delivered before the services switched the tool on in NADAbase so that the screening was introduced alongside skills and confidence rather than as a data task. Initially, 27 services opted in, including women's residential services, community-based services, family and other community programs. Slightly more than half of those services actively use the tool, and this points to the gap between having a tool available and having it embedded in everyday practice. The question is, where does your service sit and what would help to make screening more routine? So regardless of whether domestic violence routine screening is being undertaken, staff who suspect any client, regardless of gender, is experiencing domestic and family violence should ask direct questions about the violence and respond appropriately to the disclosures, which is consistent with the DVRS and the identifying and responding policies. And templates for these policies are available in the NADAbase toolkit. So now I'm going to hand over to Millie to talk about why it actually matters in AOD services.
Thanks, Michelle. So why does the DVRS matter in AOD services? Domestic and family violence is a significant public health issue and can affect physical health, mental health, substance use, parenting, housing stability, and treatment engagement. Domestic and family violence can happen to anyone. The intersection is not always clear. Some women experience multiple overlapping challenges, including discrimination, disadvantage related to their own identity or situation that could heighten the likelihood, impact, or severity of violence, as well as experiencing additional barriers to seeking support. Services are often a key point of contact for women experiencing violence. AOD services are often the first or only place women experiencing violence can safely seek support. I imagine there's a good chance that AOD workers online today will have already had or at some point work with clients that are experiencing family violence. Routine screening helps to identify if domestic family violence is occurring and the potential impact this may be having on the woman. It also highlights the importance of safe responses and referral pathways from staff and services. Women in Australia continue to be disproportionately impacted by family, domestic and sexual violence. Gender inequality is a driver of violence against women. Gender is the biggest risk factor for domestic violence. Women and children are most at risk of domestic violence from male perpetrators, predominantly their current or former partner. Research indicates that domestic violence experienced by women is more severe and frequent than domestic violence experienced by men in heterosexual relationships, and that women are more likely to be seriously injured or die at the hands of a male partner. It is most common for this type of violence to be perpetrated against women by men. So why limit screening to women? Limiting screening to women is also an additional safety mechanism to reduce the potential of male perpetrators becoming aware of the DVRS process, which their woman partner may be asked when they access one of your services. Disclosing violence itself is a risk. It takes trust to disclose domestic and family violence, and it's important to ensure it leads to support. We recognise that men also experience domestic violence. However, due to the low prevalence rates in this population, we don't routinely screen. Women are more likely than men to identify relationship issues as a cause for their problematic substance use. Women in treatment have much higher rates of experiences of domestic family violence than women in the general community. Initial responses to disclosures of violence can be crucial for enabling immediate and longer-term support for women. It's not possible to know who is experiencing domestic family violence without asking. Women presenting at AOD services may have been impacted by domestic family violence and not disclosed. So it's so important to address any needs that they may have by including screening questions on intake. So here's some of the a definition that you can see on screen. So domestic violence is a type of family violence that occurs between current or former intimate partners. So sometimes this is referred to as intimate partner violence. Family violence is a term used for violence that occurs within family relationships, such as between parents and children, siblings, intimate partners, or kinship relationships. Family relationships can include carers, foster carers, co-residents. So when you think about group homes, boarding residences, Both family violence and domestic violence include a range of behaviour types. Domestic and family violence is a violation of human rights. It includes any behaviour in current or previous intimate relationships or family relationships which is violent, threatening, coercive or controlling, and causing a person to live in fear. Domestic family violence is predominantly, but not exclusively, perpetrated by men against women and their children. So while there is no single definition, the central element of domestic and family violence is an ongoing pattern of behaviour aimed at controlling a partner through fear. The violent behaviour is a part of a range of tactics to exercise power and control over women and their children. It can be both criminal and non-criminal. It's usually manifested as part of a pattern of controlling or coercive behaviours used to gain or maintain power and control. You would be familiar with the power and control wheel, which is a helpful tool in helping to understand the overall patterns of behaviour which are used to establish and maintain control. Some of these behaviours you may recognise more than others. It's important to recognise, though, that many women experience multiple types of violence at different points of their life, and this may look very different. So here are some of the key definitions. It's important to remember violence can take on many forms. It can be physical, psychological, emotional, financial, sexual. You can see here on the screen that the definitions of types of violence in the personal safety survey and the types of partners that are considered. So the Australian Bureau of Statistics conducts the personal safety survey every 4 to 5 years. So care is needed with the terms violence by an intimate partner and intimate partner violence when looking at the data. We know data sources can vary widely in definitions used with the data items collected and reporting mechanisms. For example, the World Health Organization uses the term intimate partner violence to refer to what is more closely aligned to definitions of domestic violence. When referencing other sources, we would use their terminology to ensure consistency with the original source. This slide that you can see is from the Personal Safety Survey, who use the term violence by an intimate partner. It's important to note that the Personal Safety Survey does not include psychological or emotional abuse in their definition of violence by a partner, although emotional abuse by a partner is collected as a separate category of violence. It also does not capture the ongoing pattern of behaviour, control, fear, and safety elements of common definitions of domestic violence. So the Personal Safety Survey found 1 in 6 people experienced physical and or sexual violence since the age of 15 by either a current or previous partner, girlfriend, boyfriend, or date. And this also included, this included 1 in 4 women and 1 in 13 men. Whilst statistics on violence by a partner gives us some insights into domestic violence, it's important to explore additional dynamics that may make violence more like domestic violence. So that could be the presence of power and control, severity of impact of violence, also threats and history of violence are also important to consider and give us some insight. Domestic violence routine screening has many benefits and can help to reduce the severity and impacts of domestic violence through early identification and intervention. It can inform women about the nature of domestic violence and available support, even if they're not quite ready to disclose. It can provide women with a response more tailored to their specific circumstances and needs. It also helps to assess the needs of and provide appropriate support to children and young people experiencing domestic violence. So, what are the expectations of staff completing screening in AOD services? So, staff are expected to understand the dynamics of domestic family violence, recognise links between AOD use, health, and domestic family violence, provide advocacy and support for the woman, use trauma-informed practices, supportive language. We also want to be conscious of your power in your interactions as a worker. It comes back to trauma-informed practices. We know violence occurs in a context of power and control. To respond to disclosures effectively, it's important to recognise the power we hold as workers, ensure to provide opportunities for the woman to collaborate in any response. Also, as a worker, we want to think about your own safety following a disclosure. EAP, supervision, for you to access support, speak to your supervisor. You may have had your own experience of violence, so this is really important. We sit in a really privileged position as workers to hear these stories. So who do we screen? New South Wales Health requires domestic violence routine screening for women aged 16 years and over, accessing mental health and alcohol and other drug services. NGOs are encouraged to screen all women over 16 years for domestic family violence, and this includes trans women and women not assigned or presumed female at birth. Screening with the DVRS is conducted in 5 phases: the preamble, screening questions, response to answers, information, and referral and documentation. So we want to think about safe screening. What does that look like? It is an intentional and supportive process. We want to create space for disclosures. We want to build trust by remaining engaged and authentic in the moment and ensure that screening is a pathway to ongoing support. We want to choose a private setting. Screening is not to be conducted with anyone else present, and that includes a woman's partner, ex-partner, friends, family members, and children aged 2 years or over. We need to help minimise the shame. Trauma and violence creates shame, and shame can also be caused or triggered by interactions with workers. Use professional interpreters if needed. We don't want to use partners or children as interpreters. The timing really matters. When is someone clinically able to engage? For Aboriginal women, historic and ongoing systematic racism and harm in care can mean that safety and trust in screening should not be just assumed. Aboriginal women should be given the opportunity to have an Aboriginal health worker present or conduct the screening whenever possible. So I will hand back over to Michelle to go through the phases.
Thanks, Millie. So we'll go through the 5 phases and start with delivering the preamble. So setting up screening as routine, not as a personal judgment, is the important bit. The preamble normalises the questions and gives the clients choice and control. We use wording such as, we ask these questions to everyone who comes in here because domestic violence is common and can affect people's health and well-being. We give people time to hear and to listen and pause to explain confidentiality and what the limits of that are. We check understanding before moving on to the screening questions and stay calm and non-judgmental, and we watch for signs that the person might need a bit of time out or a break from questions. So phase 2, so the priority in this phase is consistency and safety when we're asking the screening questions. Ask the approved DVRS questions exactly as required by the service process and avoid softening or paraphrasing or minimising the wording because that can reduce the clarity, and actually change the meaning of the question. We need to allow the space for silence and notice any verbal or non-verbal cues, but don't pressure the client to disclose or provide details. If a disclosure does occur, slow down, acknowledge what's been shared, and shift into a safety-focused response rather than investigation. So phase 3 is responding safely. So we start with the validation. Thank the woman for telling you. Acknowledge that what they've shared is important, and we can state clearly that the violence is not their fault. Consider immediate safety and urgency as well. Use these red flags on the screen as prompts for risk awareness, but not as a checklist to be read out. We listened for escalation in violence, coercive control, stalking, strangulation, threats, access to weapons, pregnancy, isolation, and barriers to help seeking. We need to reinforce that alcohol and other drug use may add complexity, but does not explain away the responsibility for violence or reduce the need for a domestic and family violence response. So here we can connect the immediate response to the formal consultation, escalation, and risk assessment pathways as the second part of this phase. So look to local procedures to know when to consult a supervisor, follow the procedures, or refer to a specialist domestic and family violence service. The DV-SAT, as a shared risk language tool, supports coordination across services. It doesn't replace professional judgment, cultural safety, or local policy. The key practice point is to move on from disclosure to a coordinated safety response rather than leaving the worker alone to manage the risk. Phase 4 goes into referral pathways and support options. So referral is valuable even when the woman is not ready to take action today. We offer options respectfully and avoid creating any pressure. We can name the types of supports available, so the specialist DV services, health and social supports, and internal consultation pathways. Discuss safe ways to provide information as well, especially where phones, emails, messages, or shared devices may be monitored by the partner or ex-partner. Where serious threat is identified, follow the local escalation pathways and coordinated response immediately. So the last phase is the documentation and information sharing. So documentation should support safety, continuity of care, and accountability. Record the facts clearly. So what screening occurred, what the client said, what was observed, any actions that were taken, referrals offered, and any follow-up or consultation. As per usual case note procedures, avoid any judgmental language, speculation, or conclusions that are not supported by the information you have. Before sharing information, check legislation, policy, and local procedures and consider whether a record or message could increase risk if seen by the person using violence. So going through all these stages, it's really important to maintain our trauma-informed and culturally safe practice. So that's the lens that sits across every phase of the DVRS screening and response. Trauma-informed practice means giving people as much choice, control, and predictability as possible. We explain what's happening, seek consent where we can, and avoid rushing the conversation. And cultural safety isn't an add-on, so it's important to recognise the disproportionate impact of violence on Aboriginal women and children and offer access to Aboriginal staff, cultural support, or specialist services where needed. We also think about barriers for women with disability, multicultural communities, LGBT clients, young people, and people in rural and remote areas. The key message is to avoid assumptions and tailor communication, referrals, and follow up to the person's context and preferences. This is a quick walk through the trauma-informed care principles and how we connect each principle to practical service behaviour. So we can see on the screen, it goes through the aspects of safety, trustworthiness, choice, collaboration, empowerment, and cultural and historical and gender needs. This work can also affect staff and worker well-being, and it's really important to have access to supervision around this. So it can affect people personally, especially when they hear traumatic experiences or have lived experiences themselves that may or may not be disclosed. It's normal to need support, so normalise it. Supervision, peer supervision, cultural supervision, and debriefing and employee assistance supports are part of safe practice. It's not a sign that someone's not coping. It's also important to notice your own warning signs, use boundaries, take breaks after difficult conversations, and seek support early. For managers, the key message is to create psychologically safe workplaces with reflective practice, clear escalation pathways, and permission to debrief. So worker wellbeing is part of the ethical and sustainable domestic and family violence response practice. 1-800-RESPECT can support professionals who are assisting people impacted by domestic and family violence, as well as people who are seeking direct support. Full Stop's another service that you can access, so it provides free, confidential trauma specialist counselling and can be relevant for workers, colleagues, families, and friends of people who are affected by domestic violence. There's also access to your internal supervision and escalation pathways, as well as these external sources, especially after complex or distressing disclosures. Seek support early and model the same care and safety that you would be offering to clients. So now we're going to have a look through a case study. So this isn't a script that is you would follow exactly. It's just an practical example of how it might go and the steps that we go through. So we have two scenarios which are different but equally important practice situations. One is where the client discloses and one where the client does not disclose, but there are indicators of possible risk. So we've got Sarah. So we'll go through that one first, and then that's where she does disclose that there is violence. And then we go through Marta's scenario, which shows that screening can be valuable even when someone doesn't disclose. So we focus on offering people choice, confidentiality, safety planning, referral pathways, and factual documentation as the scenarios unfold. So meet Sarah. Sarah's scenario highlights both the AOD context and the relationship safety indicators. So Sarah's in residential treatment, which creates an opportunity for a private conversation away from her partner. It doesn't remove the need for careful safety assessment. We can notice the indicators that she's presenting with. So she's anxious, there's avoidance, bruising, reluctance to discuss her home life, references to her partner's temper and increased alcohol use after arguments. While these indicators don't prove domestic violence on their own, they can tell us to proceed calmly with the routine screening and be ready to respond safely if disclosure does occur. The key point is to avoid assumptions while still taking the indicators seriously. So here we'll go through the phase 1 and phase 2. So a clear preamble followed by the approved screening questions. The preamble normalises the questions, explains why we're asking them, gives Sarah permission not to answer, and outlines confidentiality and its limits. After Sarah says yes to the first question, we avoid rushing into detailed questioning or asking for unnecessary information. We maintain a calm posture, steady tone, and simple validation to help reduce the shame and support emotional safety. The next step is a safety-focused response, not an investigation or a judgment on her situation. So phase 3, we show the transition from the disclosure to the immediate safety and risk awareness. Our first response on this slide validates Sarah and clearly states that the violence is not her fault. Then we check her immediate safety in the current setting and begin to identify risk factors that may require escalation or specialist support. Strangulation, escalating physical violence, children witnessing any violence, and uncertainty about returning home are serious safety concerns. Here we would follow local procedures, consult appropriately with external domestic and family violence specialists, and avoid leaving any staff member to manage the risk alone. So phase 4 and phase 5 goes on to the response, referral and documentation. So we complete Sarah's pathway through this screening by connecting the disclosure to the referral, the safety planning and the documentation. A warm referral is much stronger than simply handing over the phone number because it helps reduce barriers and supports follow through. Discussing the DV and involving a trained colleague can support shared understanding of risk and coordinated action. Safe contact is essential, so check phone access, privacy, monitoring, and whether messages or written information could create risk. Documentation should be clear, factual, respectful. Record what Sarah said, what was observed, actions taken, referrals offered and accepted, child safety considerations, and any follow-up plans that you've made. So now we'll meet Marta and go through a scenario which is different, but it's still common where people don't disclose. So there are indicators of risk, but she may not be ready or able to disclose. Marta's partner's waiting in the car park, which is an important safety consideration. It may affect what she feels able to say and whether it is safe to provide any written information when you're talking to her. Note the indicators over time. She's missed appointments, withdrawn, tearfulness, sleep difficulties, anxiety, and she says that her partner's been monitoring her phone and social media. Monitoring and controlling behaviours may indicate coercive control, so the worker should respond carefully without forcing a disclosure. The key message here is to create a safe opportunity and respect for Marta's choices. So in this scenario, screening without disclosure, this demonstrates how to respond when Marta answers no, but shows signs of distress or concern. We still deliver the preamble and ask the questions routinely, but do not challenge her answers or try to convince her to disclose. The example response leaves the door open and communicates that support is available if she wants to talk later. It's appropriate to gently name that monitoring and controlling behaviours can be connected with domestic violence while making it clear that Marta does not have to label her experience as such or disclose it today. The emphasis is on respect, choice and safety. There's no pressure, no interrogation and no visible reaction that could increase shame or fear. So moving on to referral and documentation, it still matters when there's no disclosure. We offer support information in a universal way, such as we offer this to all women entering our service. So Marta doesn't feel singled out and can choose whether or not to use the information. Before giving written information, we consider whether her partner may find it. Safe delivery of the information can be just as important as the information itself. Documentation should state that screening was completed and that Marta answered no, then record observable indicators factually and without judgment. Include any relevant observations such as phone monitoring, sleep difficulty and anxiety, and plan to re-screen when safe and appropriate. We also need to follow child wellbeing and mandatory reporting or information sharing pathways if required. So here are some examples of how we could approach the conversation, what we might try saying or things we might need to avoid. In both these situations, we need to consider children's safety and well-being. So whether it's disclosed or whether it's suspected. If violence is disclosed, we need to assess immediate risk to the children, consult supervisors, follow mandatory reporting and child wellbeing pathways, and make appropriate referrals and document the actions. If there's no disclosure, we still need to remain alert to indicators of harm and seek guidance under organisational policy. Questions should be safe, non-leading, and appropriate to the context. Documentation should separate what the client says, what was observed, and the action that was taken. So it's a really good idea to know where your local child protection procedures and reporting tools are located within the organisation, and also your local domestic and family violence specialist services and child protection services before the situation arises that you need to use them. In the NADA policy toolkit, we do have a child protection and reporting template that can also be downloaded and used to support this. So now we just take a bit of time to reflect. It's always good to practice scenarios and practice having the conversation to make it more comfortable. So we can reflect on what might, some of these questions on the screen, what might make the client more comfortable. So for question 1, we can listen for privacy, routine screening, clear confidentiality information, calm tone. For question 2, draw out reasons why a disclosure might not happen. It could be fear, shame, surveillance, concern for children, and potential for involvement with DCJ, previous poor responses, cultural barriers, dependence on the person using violence, or not recognising the behaviour as violence, which can occur as well. For documentation, we can compare Sarah's clear disclosure and safety concerns with Marta's no responses and observed indicators. Both of these scenarios require factual, respectful notes, but the level of detail and the action pathway is very different. If Marta discloses later, the approach should be the same core pathway: validate, assess safety, consult, refer, and document, while recognising that trust may have been built up over time and made them more comfortable to disclose. So we can link all of this back to the trauma-informed principles of safety, trust, choice, collaboration, empowerment, and cultural responsiveness. To recap on the 2 scenarios and the decisions we make at each point of the DVRS pathway, we can have a look at this table. So Sarah's scenario shows the pathway when this results in a disclosure. So validation, immediate safety assessment, risk identification, warm referral, specialist consultation, and detailed documentation. Marta's scenario shows that no response is not the end of the practice. We can still create safety, provide universal information, record observations factually, and plan to rescreen when appropriate. We can notice what's the same across both scenarios. So the routine preamble stays consistent. We have respect, privacy, choice, calm tone, attention to safety, and factual documentation. What differs? It's the level of risk assessment, the referral urgency, child safety action, and follow-up planning, which depends on what is disclosed. The key lesson is that the DVRS is not only about getting a disclosure, it's about creating a safe, structured, and trauma-informed response every time. So now I'll hand back to Millie to talk about safer pathways and safety action meetings.
Thanks, Michelle. So, how do we take appropriate actions in response to the person's answers? You may be familiar already with safety action meetings. You may attend them in your local area. What a safety action meeting is, it's a fortnightly local coordination session used in New South Wales under the Safer Pathway framework. It's to protect adults and children at serious threat from domestic and family violence. So key government and non-government agencies collaborate strictly behind closed doors to share information and build specific safety plans. So it'd be worth having a look into your local safety action meetings if you're not already involved. So what are our key takeaways from today? So screen routinely. We want to ask every woman aged 16 and over the DVRS questions as part of standard practice, not only when we suspect violence. We want to ask safely. We want to choose a private setting away from partners and family. We want to check in that the client is settled and able to engage clinically before beginning. Let's respond without judgment, validate disclosures, acknowledge that violence is never the client's fault, and respect decisions not to disclose while leaving the door open for any future conversations. Know your referral pathways. Get familiar with local specialist services, the DVSAT process, 1-800-RESPECT, and your own organisation's escalation and consultation procedures. This may differ between and will differ between services. Let's document clearly. Record that screening occurred, the client's responses, what actions were taken, and referrals offered using factual, respectful language that distinguishes observations from disclosures. Look after yourself and your colleagues. The DVRS can bring up really difficult content. Use your clinical supervision, peer debriefing, employee assistance supports, and check in with colleagues who may be affected by what they hear. What's your commitment from today? So we want you to have a think about before you leave today, what is one thing that you may do differently as a result of this training? So it might be, I will start. What is one new practice you'll introduce into your work with clients? Is it trauma-informed practices? Do we think about the environment, not only our responses and our own responses to the situation, but also what's the environment like in your service? We want to strengthen. Which part of the DVRS process do you want to build more confidence in? Is it the preamble? Is it referral pathways? Do you know your local specialist services? Is it case noting and documentation? I will share. How will you bring what you've learned back to your team or service? Is this through team meetings, case conferencing, clinical supervision? Every time you ask the question safely, you create an opportunity for someone to be heard, and that really matters. If you'd want any further information on this webinar training today, if you've got any questions, please reach out to Michelle or myself. Thank you for joining us.